Yeah.
So we have gone live, and Shilpa madam, you can start.
Yeah. Hi, everyone. So, welcome to this very interesting session today on vascular injury, which happened today in Dr. Jay's OT. So, vascular injuries, I have been asking him to take a session because we get a lot of these queries on our personal chat box as to how to tackle, how to manage if there is anything. And many a times when we come across this, it is such a panicky situation. I have seen myself do a vascular injury to external iliac, and then I have seen Dr. J do injury during his surgeries, and the way we tackle it is all like something which we wanted to discuss and also educate people as to how to maintain the calmness in the OT and also how to have that preparedness when such things happen. So, since laparoscopic surgeries are getting more and more advanced, and also people are willing to take up that challenge and do tough cases, especially in endometriosis or in cases of PID, we come across these situations where there could be vascular injuries which is expected, or in some cases where even when it is not expected due to some movement or some kind of error in our judgment, we can injure these vessels. And it is very important to actually understand in a stepwise manner and also how to prepare your team. Like Dr. Jai has got Arun sir here today, which is a very good thing because anesthetist is a very important part of the management of these vascular injuries. So over to you, Arun sir. You can start with your few
Yeah.
words that you want to speak.
Arun sir, before you start, Vismay, I just want you to briefly, very briefly and very quickly describe the injury and the exact sequence of events, like how it happened. And I was not in the OT and I was somewhere else, and I was called in the OT to get it done and get it repaired. And the exact sequence, okay, like how it happened, maybe in 2 minutes, because then by the time I reached in the OT, you and Arun sir had already done the initial management, right? And I just came and did nothing much. I just sutured everything off. But I want you to brief, because this is exactly how a vascular injury would happen. So guys, I wanted to mention it to you that this was a case where Vismay was operating the case as quite a lot of times for endometriosis. And I was in the consulting because I mean, of course, nobody plans a vascular injury, and I was in the consulting. And Visma, you can take it over and you can describe the exact sequence.
So actually, so the injury can be divided into actually two sequential things happened. So first, as I was dissecting the pararectal spaces, the intestine was densely adherent to the left ovary. So this I'm talking about the left pararectal space and the left uterus. I was able to dissect the pararectal space as we do the Jaisa's technique, where I directly go to the till the level of the levator ani. And as I was trying to come proximally, there was this small vascular injury, bleeding from a vascular, probably a small vein which was coming. It was not very something which was not tackleable. I was able to tackle it. I just put my suction there, and I was able to locate that, and I just coagulated it, and it stopped within like probably 2 to 3 minutes, and there was not much of a blood loss. Of course, there was this a layer of coagulum had formed over this the vascular vessel injury, no, sorry, vascular vein or an artery. And I continued with my dissection. I continued with the right-sided dissection. I had mobilized the bowel, and there was this one place where I was trying to find some kind of a plane. And this was the second thing what it happened. And this happened after like probably 20 to 25 minutes into the surgery. After that thing, the first coagulation happened. So I just passed my suction over it. It was just a general suction when you just try to remove everything. There was this small blood and collection everywhere. I was just suctioning it off, and without my knowing, the suction just went through that coagulum. And as I just went through the coagulum, that coagulum might have ripped off from that vessel, And that small injury then just turned out to be this big shearing off of the vessel, and then the torrential bleeding started to happen. So once that bleeding started to happen, as I know, immediately the anesthetist Arun sir was there. Arun sir was he immediately ordered for blood products. We prepared. Of course, we had prepared for a laparotomy in case if it was required. We prepared vascular clips. So we have both this vascular clips, which are metal ones, and we also have that the plastic ones. We also prepared for the laparoscopic bulldog clamps, the laparoscopic vascular clamps, and I informed Jai sir about it. We were also very ready with our sutures. If any sutures which were eventually required during the surgery, the 5 mm lateral port was immediately converted into a 12 mm lateral port, and first of all, as Jaisar had, he will eventually said that we tried to keep that area clean by suction, but which was a mistake which was done by me, as he had said it during the surgery that the suction was not required, and I immediately tried to catch the bleeder, the point bleeder, through a laparoscopic bipolar insert. So I just digged in my laparoscopic bipolar as deep as possible, and I just grabbed the vessel. And fortunately, that vessel completely got grasped in the bipolar. And by that time, I was doing nothing. I was just, and the bleeding completely was halted at that point of time. The flow reduced, and that gave me some time to do my other things. I just suctioned it off. I was trying to locate it. I was trying to divide the ureter. I was trying to lateralize the ureter from all these places. And then, of course, Jai sir came and we did the whole
Right.
repairing that.
So Vismay, we will be showing it live in a little
Yeah.
while. Arun sir, you can take over.
Yeah. So she was the young patient, 35 years, blood group was O positive. Many a times we do reserve some 1 or 2 pints of blood for such patients. Somehow for this patient, blood was not reserved. But when we had taken the patient in the operation theater, her the vein flow, which generally we have a 20 gauge vein flow pre-operatively, it was not running that smooth. So pre-operatively, I had put one 18 gauge vein flow on the other hand. Generally, if I put a vein flow in the operation theater, I prefer a larger bore. So I had put in the 18 gauge, which was very fortunate that I did it pre-operatively. So when I noticed the events intra-op, like how Vismay described the events, and I saw the suction bottle within few seconds or within a minute or so, she had bled about 2 liters of blood. So fortunately, the vitals were fine, just little tachycardia, but there was no hypotension ever. So I immediately ordered for 4 pints of blood and 2 FFPs. I could have ordered 2 more FFPs, but I was convinced with 2 FFPs and 4 blood. And I immediately started pushing Voluin, which is a colloid. So I gave 2 Voluin IV bolus. I sat at the IV line and I kept on pushing them so that I didn't want the hypotension for this patient. Fortunately, the blood had arrived within 20-25 minutes, and I again pushed the blood with the syringe. So you can say within 15 minutes or so, I had pushed 4 pints of blood and 2 FFPs. Patient was stable throughout. By then, the Jay had taken over and all clipping and suturing was done. So basically, she had never become hemodynamically unstable at any point of surgery. So it was a very well managed and a team effort game.
Yeah. So thank you guys for pitching in. Now, 2-3 things are very important, which I want to tell and then give you some logic as to how you can handle, right? So just remember some rules of vascular injury when they happen. First, you will never have a planned vascular injury. Okay, you can never ever plan a vascular injury unless you are doing lateral pelvic wall excision, which you do in very widespread endometriosis, where we plan it, where we plan to cut the internal iliac vein and internal iliac artery. Apart from this, in gynecology, you never plan a vascular injury, right? The first rule of any vascular injury, first rule, okay, is that automatically there will be a lot of gush of blood, isn't it? Now, your first rule is do not panic. Okay, I know it is very, very tough to follow, but the rule is do not panic. Okay, just in case you have understood the first rule, then comes the second rule of vascular injury, and the second rule is again do not panic. Okay, please do not panic. This is the most important take home point if in case you want to have as far as understanding of this surgery is concerned. Remember one more thing. Pelvis is covered on its lateral extent by bones. So you have the ilium, you have everything else, all the sacral promontory, ilium, ischium, everything is there in the pelvis as bones. Where are your vessels located? Vessels are located just above the bones. So if you do not understand anything with the first instrument which is available inside, it can be a bipolar grasper, it can be a needle holder, it can be suction, it can be whatever, just compress that vessel against the bone. Till you do not understand anything, just apply pressure. The most important rule is apply pressure. Okay, so your one port goes in applying pressure. Once you apply pressure over that vessel from that one port, then please do not fidget for 5 minutes. Just keep on applying pressure over that. What is going to happen is in that 5 to 6 minutes, you will get an opportunity to change your ports. Like how Vismay mentioned, 5 millimeter port becomes a 12 millimeter port on one side. So your stapler clips, so your vascular clips, anything which you require goes inside very easily. Gauze piece, if you want to put inside, the gauze piece goes inside very easily. Though we never encourage to put gauze pieces. Okay, we have never put gauze pieces in vascular injuries. Just put that instrument. So one hand of Vismay never moved for the first 10 minutes. That was a very important point because his hand was continuously pressing that vessel. At this moment, we were not aware which vessel it was. We were not aware if it was external iliac artery, internal iliac artery, external iliac vein. What it was, we were not knowing. We just knew because there was a lot of blood loss. Arun sir mentioned we lost around 1 liter blood in less than 1 minute. Understanding. So you can imagine how much the blood loss must be. Yeah, we lost 2 liters blood in maybe 1 to 2 minutes. So you can imagine how heavy the blood loss must have been. Okay, and I'm going to show it to you. Okay, so what typically happens is please make sure that one guy is pressing that vessel on. Whatever he has pressed on, just press that vessel onto the bone. Once pressure has been applied, please do everything else. Arun sir had got central line ready by then. I remember this because when Vismay had applied pressure and ice converted from 5 mm to 12 mm port, Arun sir had applied, got ready with the central line if at all it was required, isn't it? All the peripheral things which you have to do, please finish it off. You know what? We organized the entire vascular clips. So we have vascular clips of steel, we have vascular clips of plastic, we have a 10 mm. But these are not the instruments which are going to be kept on your trolley. These are instruments which are going to be present in your plasma or autoclave set. Correct? So you have to allow your nursing time to get it ready. In that 5 to 10 minutes which Vismay bought us, one more nurse washed up. That nurse also came onto the assistant trolley. One person washed up and came to Dr. Arun. One person made sure that because I have randomly come inside the OT on emergency. Okay, I have quickly scrubbed. I have joined inside the team. All this can happen when you are applying pressure, and this application of pressure is something which is critically important as far as this surgery is concerned, because it will help you go a long way as far as this surgery goes. Understanding? So please keep that in mind very vigilantly. That is the second thing. Now, third thing, which I think is very, very, very important. Remember, if you are looking at the pelvis, okay, the most important vessel in the pelvis is internal iliac artery. Correct? Internal iliac artery is completely sacrificable. I mean, if something happens to the internal iliac artery, nothing, just cut it. Nothing will happen. Understanding? With these 3 points in mind, okay, I will switch to the screen sharing where I will show you the exact video of how the events happened. And then there'll be a lot of points to discuss because I'll be stopping the video in between. I want to tell one more thing. See, I sutured with my right hand, left hand, and I used Vicryl number 1 because the injury was big, and the needle was not going on and the clip fell off. Okay, after I put the clip fell off. So I'm going to show that part also. So be very good at endosuturing. See, I think Arun sir and Vismay will agree. What saved us today was endosuturing. You know, we very, very quickly sutured everything very fast. Our suturing was super, super fast. Okay, and super fast in such a close space. Okay, with a large needle. I'll show you the needle, which needle I used to suture. So be good at endosuturing. Really, it will save your day. When it is required, you will not understand the importance of endosuturing unless you face a day like this. Okay. Second thing, very important, and I think even Arun sir and Vismay, because we are having an open conversation with all of you, they will all agree. Be very calm. Okay, don't panic. If you panic in the operation theater, then your staff will just not know what to do. Believe me. Okay, if you are calm, you will be in a position to give instructions to people. See, most of the people don't know how heavy bleeding is called heavy bleeding. Understanding? Because even the staff is not, I mean, I know some of my staff is used to seeing madness as far as vascular injuries are concerned, but most of the staff is not trained into all these things. Okay. There was one guy who was helping Vismay clean the camera. After 1 or 2 times, even Vismay did not required to clean the camera because we had arrested most of the bleeding very quickly. Okay. So having said this, let me switch straight onto the video. So all of you, I mean, Visma and Shilpa madam can stay unmuted because I'm just sharing the screen. Just let me know if you can see the screen, guys. Okay. Screen is visible?
Yeah.
Yes.
Okay. Thank you. So, yeah, see this is how it started. Can you see? Nothing Visma was doing, and see that. Can you see that blood vessel? So at one given point in time, we thought it is the common iliac. Understanding? I'll show it to you again. See, nothing, just suctioning was happening, and in suctioning that coagulum sheared off. I hope all of you noticed, correct? At this juncture, you can't notice where the bleeding is from, but all you can notice is it's a large bore bleeding, correct? One more time. So this was when I was not in the OT. This is when I'm not in the OT. Okay, I'm outside the OT. See this. Can you see that bleeder, everybody? Beautiful, no? So now, just a minute. This is that Vismay is holding on to that bleeder. Can you see that? With the bipolar. That is the internal iliac artery which I am holding with the shearer. That is external iliac artery. That is common iliac vein. So now I will pause here. The most important thing in vascular injury is once Vismay has held that bipolar there in order to prevent the bleeding. As a laparoscopic surgeon, please dissect that region. Please dissect that region. Isolate the vasculature. If you do not isolate the vasculature, it is going to be impossible for you to go and take stitches. Believe me, if you do not isolate these vasculatures, you will simply not be able to, absolutely not be able to take any of these sutures. Okay, you will not be able to take sutures. So we first went and we dissected all of this. Okay, now see that I'm dissecting, I'm doing some time pass. That is the sacral promontory. No panic, all chilled out. I'm recording the video, guys, when I'm doing all these things, understanding, so that just in case somebody asks me to demonstrate, these days my demand for demonstrating complications has gone up. So just in case somebody asks me to demonstrate, we can demonstrate, hai na? But you see that is that uterus. Nicely we are just just cutting off everything. Bhai, tu bhi thoda side mein ja, thoda jagah de do. You know how it happens. We are requesting the vessels basically. Thoda side mein, go little. Okay, but we request in Hindi. We don't speak in English to the vessels. So slowly, all the vessels are going away. You can see I'm coagulating in that plane, cutting, just separating. And that vessel which you see that is the external iliac vein. See that beautiful vessel. See, nice, no? That I've paused there. See, can you see my marker over the external iliac? This thing, Shilpa ma'am, can you see that marker? Yeah, that is the external iliac vein.
Not really.
Beautifully, it was bleeding. See this one. This external iliac vein. It was so nicely bleeding. I'll show you. See, that is external iliac vein. Can you see? Full external
Not
iliac vein.
clear.
See? Not clear, huh? And that ovary had pus also. Can you see that pus coming out from that ovary? Now, till that moment, we had not done oophorectomy, okay? See that pus coming from the ovary. Can you see? Pus coming from the ovary. So bus underneath that is external iliac vein. Okay. Full external iliac vein. Nice it is. Slowly, it was bleeding. Okay. So, I will just go to the next thing. After I stopped all of that, see this. This is what we did. Can you see it, Shilpa madam? Now can you see?
Yeah.
Now see, this is Vicryl number 1. What is this?
Vicryl.
Not 203040. See the number 1. And see, clips were not going there. So what do? You just take the Vicryl around the vessel. See the. Okay. Now this is a very closed space, guys. This is not very easy space to pass this. Can you see? We just passed that needle only directly through that. Okay. And we will take our first stitch at internal iliac artery. See, the best thing is to suture is internal iliac artery. How we do it in PPH? See, that is internal iliac ligation, just laparoscopic, nothing other difference. That is that ureter just going by the side. We have not dissected anything. That is external iliac, that is internal iliac. Just go and ligate internal iliac. Ekdam mast. Okay. See, full internal iliac we would ligate there. I'll show you. After the internal iliac is ligated, we thought we will ligate more veins because there was no place available, honestly. Same thing. See, stitch underneath the vein. Can you see? Large Vicryl number 1 needle and strong suture material. Just only problem is no place is available. Understanding? Because it was a huge bleeder. So that is one more vein. That is common iliac vein, okay? Which we have ligated. Common iliac vein ligated. Internal iliac artery ligated. Okay, we will take our ligatures now. See that? That is internal iliac. That is common iliac vein. So we will just ligate it now. See, it is difficult to ligate with your sutures because your hand movements is going to be so restrictive inside a situation like this. But still, you know, you have to manage. You can't be giving an option there. See, must ligation has happened. Can you see? See, beautiful ligation. Full ligated. So what this will do, no? Automatically the amount of bleeding which you are experiencing inside, automatically that amount of bleeding from there is going to go down. Automatically it will go down. You should simply not worry. And I am using Vicryl number 1. So remember one thing, I am using Vicryl number 1 for ligatures. I am not using it to reconstruct the vein. Understanding? This is purely for ligatures. See, full ligature done. Nice, clean ligatures. Can you see that? Nice, clean ligatures are done there. Now with that ligature done, of course, our scissor will come and we'll cut it. Okay, see that with the scissors we are cutting. And see, Visma is bipolar has not moved. All the surgery, if you see, Visma is Visma. Now finally, I have switched from his instrument and I am holding it with the sharer because I wanted to pass my needle below that suture. So you have to suture above, you have to suture below because it is such a heavy bleeding there. It's tough to do that, no? So I passed my suture below that. You can see that I have put 2 clips there. See, 2 steel clips. I hope you can. It is looking a little shabby, huh? But remember one thing. See, doing all this and then you can't really have a clean field in a vascular injury. So I'm not even changing instruments. I'm just using bipolar as suture holding and sharer. You will see the beautiful bleeding coming still. See that. So that is my ligature. It has gone beautifully ligated that region. once, see, okay, then it's not ligated. Now, once it goes and ligates all of this, again, life is becoming easy. You just take it out. See this beautiful. See the bleeding now. Huge it is. See, still it is coming. Can you see? So now we decided that, acha, despite doing all of this, if there is still pumping like this, then we will apply more clips in that region. Can you see that pumping? Because you are able to see that pumping, Vismay comes in again with the bipolar. That is the external iliac region. See that pumping? See? So nice it is. Full field is occupied. And again, I took it with my sharer. I just grasped it with my sharer to stop it. And I will come inside with ligatures. So these are going to be my vaso clips. You can see my masta vicryl ligatures in that region. I will be coming inside with vaso clips now. And when I come inside with vaso clips, exactly at the point where it was bleeding, see that? That is the steel vaso clip through a 10 mm applicator. See that? First ligature done. Now what you should do is when you ligate, you just remove your hold. So you will be able to see if you have actually ligated it correctly or not. Otherwise, there is no point in putting a vaso clip. You have to put the vaso clip and remove the rest of everything. So what happens is when you remove everything else after putting your vaso clip, you will yourself understand. See the second vaso clip coming in. Clip and leave it. Nothing is there on that vessel. See, everything left. I think this vaso clip came off. I'm not sure. I think it did. Now I am also not sure. So see, I'm just rubbing off everything, suctioning off, everything is clean. Till that time, I have not taken off the vasoclipper. Yeah, that is the bone. I think now when I remove, now when I removed it, you can see the bleeding has stopped. See that? So that vasoclip took care of the shearing which had occurred there. And basically, in such a situation, we were able to apply clips everywhere. So we applied total of 4 clips and the distortion of that vasculature just stopped completely. Okay, now this is your take home point as far as this surgery is concerned. Okay, when you have a situation like this, believe me, this was such a bulky uterus, 17-18 weeks. Already you can't see anything. Already there is so much endometriosis. So already the anatomy is totally gone. You have taken that anatomy for a toss. And after this anatomy has gone for such a toss, if in case you are able to go ahead and apply your clips in this type of a manner, your life is going to become very, very easy as far as it comes to doing something like this. Certain important things apart from watching this and doing. If in case you are not confident, please call for help. Do not try to do this alone. Okay. Till that time help arises, apply pressure. Second, if in case you are not, that you do a laparotomy, saving the life of the patient, where there has to be absolutely no shame in converting laparoscopy to laparotomy. Absolutely no shame. Okay, so do not think about it at all. Bindas, convert if in case you want to convert it. All right. Very, very important thing, which again you have to keep it in mind. Post-operative care. In this situation, all right, what typically happens is because you have coagulated all these vasculatures and because you have taken so many clips, there is a high chance, because it is a venous injury, okay, there is going to be no problem as far as any maintaining for function is concerned. But you need to make sure in a situation like this that you give the patient a very, very good post-operative care. This post-operative care is going to be predominantly to ambulate. This post-operative care is going to be predominantly to make sure that the patient is given coagulants, is seen by a physician and a vascular surgeon, and you do a vascular Doppler on the patient prior to discharging the patient. Okay, these are certain things which are going to be important in your vascular injuries. Remember, you can also have vascular injuries where you end up reconstructing the venous system or the arterial system, which we have shown you many, many times on Facebook and on Instagram. This was something which was predominantly related to a sharing of and clipping. And we thought sharing this live experience with each and every one of you is going to be much more advantageous for your practice. So with this, I finish, and probably I'll be able to answer 2 or 3 questions from Shilpa madam.
So I think we have to again come back to the basics like usual. So first thing is to understand whether we will be able to tackle it in laparoscopy or should we open up? I mean, what is your thought on this? I mean, everybody can't be like, an
Please
expert
have
in
no shame and open up. If
yes.
you think you cannot do it with laparoscopy, please open it up, take a midline vertical incision and just open. Do not have any shame. But when you are opening, even at that point in time with one of the side port, the pressure has to be continuously applied onto the vessel. Otherwise, by the time you open, the patient would have lost 3-4 liters of blood.
Yeah. So the second thing that you missed out, and I don't see you usually doing it, is the usage of a swab on the vessel to apply pressure. So,
Yeah.
I mean, I have never seen you do it because you directly do it with the instrument. So,
Yeah.
what do you think? I mean, applying using a gauze, like changing one of the 5 mm port into 12 mm and putting a gauze on these kind, especially the veins. So the veins,
Yeah.
usually the pressure works very well in the veins and it may not even require suturing.
That is only for
Your voice is breaking. Can you come again?
injuries, ma'am. When other part.
I'm sorry. You please
That is only
say
for
that
madam. No, that is only for small injuries, madam. If you have a large injury like this, you will require to put a pressure and reconstruct. And you know what? I am not very in favor of putting a gauze, because in emergency and in panic, if somebody forgets that gauze piece inside, then it is a big problem, madam.
Yeah. So also, I mean, I have seen this happening even in our OT when you have done cases. Like once we have seen this happening, and we were quite like, I mean, quite organized, luckily, to have the vascular clips, and we kind of like, tried to apply, and then things were in control. So in such situations, when we, especially retroperitoneum in endometriosis, how you usually say that like, the anatomy is distorted. So what is that one thing like, in distorted anatomy in endometriosis where dissection is difficult, as you said, like Vismay was holding it with bipolar and you are trying to like dissect it and it's all sticky tissue. You don't know what you're doing in your state of mind. So if the dissection is difficult, what is that one thing that you say that you can just do it? Like, can you ligate internal iliac artery? What is it like?
Sacrificing internal iliac artery and internal iliac vein is a no-brainer. It's absolutely fine to sacrifice it. No problem.
Yes. And also in situations like, I mean, vascular clips, how important these are in any OT, especially people who are doing endometriosis surgery, who are doing retroperitoneal dissection routinely.
If you are a laparoscopic surgeon, then your first investment has to be in a vascular set. You should forget investing in harmonic and all these types of things. First, invest in a vascular set. This is one thing which will save your confidence and save your practice.
Yes.
And it is very important. You will realize the importance of this when you face this. Till you do not face this, you will not understand the importance of this probable presentation. You will not understand the importance. Very honestly, it is because we are so used to doing and handling vascular injuries inadvertently. We were able to record it as a part of the injury and demonstrate it to all of you today. Correct? Otherwise, nobody is going to be in a state of mind to come and record it at that point in time. Understanding? And I think that probably shows how geared up your operation theater is, your staff is, your colleagues are, your anesthetist is, to allow all these things to happen in a smooth manner. Understanding?
Yeah.
And we must keep that in mind.
So tell me, like, in lymph node dissection, especially in sticky lymph nodes, and when you have shown previously multiple times about how the extrailiac vein is injured and you have sutured it. So in these situations, especially in endometriosis and in malignancy, what is that one difference that you find in vascular injuries?
No, ma'am. Injuries will happen predominantly in endometriosis and less in malignancies, because in malignancies the tissue is a very clean tissue. Okay, it is just inflamed if at all. But in endometriosis it is fibrotic. So because of fibrosis, if your plane of dissection goes wrong, no, even in the best of
Mm.
the hands, you will end up making the worst possible mistakes.
Correct. Correct. So in these situations, so what are the instruments that are very important? You told about the vascular clips, you told about the bulldogs, you told about the suture material, you told about the skills that are required to suture. So for a basic laparoscopic surgeon who is coming across such injuries, I mean, what is that one thing which is extremely important? I mean, is it the calmness in their approach, the staff?
When you make your primary vascular injury, you will not be calm.
Yeah.
But if you have seen many of them happen before you actually turn pro, I mean, before you go independent, then you will be very calm. So a lot of it actually depends on how you are trained and where you are trained. And if not, this is not one case where watching a video will make you confident. This is one case where you will have to learn it on table only. Okay. And believe me, it can be a scary thing to handle so much of blood, especially when you are not used to handling. So you have to go through this grind if you are a laparoscopic surgeon, because some or the other time this is going to happen. And when it happens, no, you got to be ready for it.
It's
Literally,
a
you got to
very,
be ready for it.
yeah, it's very similar to a PPH, like, the way
Yeah.
that we kind of manage and the adrenaline rush and also the team effort. It's very similar, but only thing is like, because it is laparoscopy. So few other things are also needed, and you need to know your anatomy. You need to have the right kind of staff who knows where the stuff are kept in
Yeah.
the OT, and whether it is sterilized, not sterilized, all those things are extremely important. So I think this was a very wonderful session, because this is the practical aspect of the teachings that we are having at this point in time today, where we discuss the actual management. It is not like, you copy paste something which is written in one of the journal, one of the textbook, and you just come and just say those words and then get out. It is the actual thing as to how we are doing, and how actually things can go wrong in the OT when we least expect it. So my first vascular injury was in a case of ovarian drilling, and that was the time that, like, I mean, where I just put the drilling needle and it just entered directly external iliac vein. So that was it. So then I just had to put a gauze and pressure for 10 minutes, and it stopped, fortunately. But now I think this was like 10 years back. So right now, probably, like, seeing and watching your videos closely and talking to so many lab surgeons. So I kind of probably, like, would have managed it in a more calmer way. But I think it's a great message from Project Pelvis to everyone out there, that the OT, the calmness, the instruments, and the approach, everything is equally important. And most important is your anesthetist, who can pitch in and get those blood and blood products. So FFP is like, in multiples of 4, packed cells in multiples of 2. So these are the things that only an anesthetist who is well versed with handling such complications prior would actually know about it. I have seen Arun Agarwal sir in my OT with you when he had come for an emergency, and how he actually, like, I mean, injects that blood in that 20 ml syringe so fast. I mean, that is something which is, like, very commendable, that he doesn't give time for the patient to sink, but actually makes it look like, I mean, the patient is so stable throughout, even though, like, there is so much happening. So I think this is a wonderful session. I thank you on behalf of everybody, because it requires a lot of, like, I think benevolence to help people understand such things which they wouldn't have even seen anywhere, even in the textbooks, where few lines would have just been written, not even a picture. So you are actually showing a video, and your anesthetist is coming and telling us as to what they did during this entire ordeal, and your associate is so, like, I mean, humble and telling that he did this, he did that, and then he got into trouble, and how you all actually, like, managed the case. Thank you very much. It was extremely nice of all of you, and you guys are really brave. So thank you very much, everyone who joined. I think in a short span of time, we had more than, like, what, 600 people who joined in for this session. I'm very grateful to everyone who spared their precious time. Thank you.